My name is Lucy Handley. I'm the Adult Programs Coordinator here at the library. And today, our speaker for this RVNA Health sponsored program is Dr. Alison McElhone, who specializes in geriatric medicine with expertise in dementia care, medication management, and palliative and hospice care. She earned her medical degree from SUNY Downstate and completed her residency and fellowship at Stony Brook Hospital. Dr. McElhone has worked in a variety of care settings, including home care, hospice, assisted living, and skilled nursing facilities. Now practicing at Stanford Health Medical Group's Geriatric Assessment Center in Wilton, she provides comprehensive evaluations and personalized treatment plans to support older adults in maintaining their health and quality of life. Her compassionate approach addresses the complexities of aging, ensuring patients receive the care and support they need. Welcome, Dr. McElhone.
Good afternoon. Just get my bearings here.
There's a clicker.
This one. Yep. And there's a pointer on this? Thank you for the introduction. I'm Dr. McElhone, and pretty much summed of what I do, but I am at 372 Danbury Road. I do geriatric assessment. I want to say about 75% of the time people are coming to see me for cognitive changes and or mood changes. So it is it's something that I see regularly and is very important to be evaluated, to have a thorough evaluation. So let me start off with just some definitions and terms about things that I see in the office. Something that you may or may not have heard of is mild cognitive impairment. And mild cognitive impairment is a subjective, it's a cognitive change, often something like short-term memory loss, could be some other having trouble with other cognitive tasks, but that has not affected somebody's ability to do their day-to-day tasks. Dementia is more of a progression of mild cognitive impairment where you're experiencing difficulties with generally 2 or more cognitive areas, and this has now affected your ability to do day-to-day tasks. The tasks that we look at as geriatricians are we lump them into instrumental activities of daily living and basic activities of daily living. The instrumental, they're also called ADLs. So the instrumental ADLs are things that are of higher complexity. Things like managing finances, driving, managing medications, preparing meals. The basic activities of daily living are very basic functions, bathing, dressing, toileting. So when I talk about how a cognitive problem will affect activities of functioning, it's referring to those primarily. In dementia, we often see accompanying mood and behavioral symptoms, and importantly, the level of consciousness is not affected. So one's alertness is not affected in dementia, and it's a chronic condition. Delirium is also something that everybody should really know about. This is an acute confusional state, and there is an association of altered level of consciousness and fluctuating attention. This is often associated, it is associated with a medical illness, and that can be a variety of medical illnesses, including things like urinary tract infections, infections, heart attack, stroke, but it is an acute change. I've heard people call it hospital dementia. I don't use that term, but that's the way sometimes people think about it. I do want to say that there is a relationship between delirium and dementia, in that dementia increases your risk for having delirium, and delirium, especially when it's prolonged or severe, increases your risk for dementia, or may worsen a dementia. So dementia is an umbrella term. I think about it as an umbrella term. There are different types of dementia. In the 65 plus population, the most common dementia that we see is Alzheimer's disease. That affects about, accounts for about 60 to 70% of cases of dementia. There are other neurodegenerative disorders, thank you, that make up for about 15 to 30% of dementia. These include vascular or stroke-related dementias, Lewy body disease and Parkinson's disease-related dementias, frontotemporal dementia, which has been in the news a little bit lately with Bruce Willis and a couple of other people, well-known people having it. A lot of times we have a mixed or overlap dementia, where we may have both features of Alzheimer's and stroke causing the cognitive decline. There's also something that we call reversible dementia that we will look at as part of our evaluation. These are things like thyroid disease. There's a condition called normal pressure hydrocephalus that I'll show you in a minute. The effects of drugs. There are certain things that can cause cognitive decline that is potentially reversible. So the focus of my talk today is really gonna be on Alzheimer's, but I just wanted to briefly talk about some of these other conditions. So dementia with Lewy bodies, which is again on the spectrum of Parkinson's dementia, that in the older population is the second most common cause of dementia. And here we do see, I want to say the primary feature, one of the primary features is visual hallucinations. So if I have a patient that is presenting with prominent visual hallucinations, that is something that comes to mind, or that I will be investigating more. There are other features that would suggest a Lewy body disease, including some Parkinsonism, so maybe some tendency to falls, some shuffling gait, some other features of Parkinsonism. In frontotemporal dementia, this is neck and neck in terms of being the cause of dementia in the younger population. So in the younger, less than 65 years old population, frontotemporal dementia is more common. The main features, there are different subtypes of frontotemporal dementia. Thinking about Bruce Willis, he had aphasia, or the predominant language variety, and there's a behavioral type of frontotemporal dementia where you have a marked personality change. And just to give you an example, I had a patient a few years ago who just was generally a very reserved person, and he started using explicatives and racial slurs towards random people, and had just a profound personality change. disinhibition is another feature of frontotemporal dementia. That's all I'm really going to say about that, because these are not really the primary thing I want to talk about today. Vascular disorders and vascular dementia, they are about the third most common cause of dementia, and we typically think of them as related to strokes and occurring in a stepwise progression. So you have a stroke, you have a cognitive decline associated with that, and then if you have another stroke, you have another decline in cognitive function. That's the textbook way that they present. We know in real life they present in other ways, but so again, the focus of my talk is going to be on Alzheimer's. Some profound statistics that if you go onto the Alzheimer's Association website, you can find very easily. It is an age-related illness. It's affecting currently more than 6 million Americans. In terms of dollars and caregiving hours, it's a huge expense. The pathology in Alzheimer's disease classically are these plaques, these amyloid plaques, and the tau tangles. So patients with Alzheimer's, this is what their brain will look like on slides. And then you can see, like, grossly the differences between a healthy brain. This is the hippocampus. This is where the short-term memories are stored. And then this is where the disease starts, by the way. And in severe Alzheimer's, you will see that the tremendous loss of brain tissue. Usually, again, the disease will start here in the hippocampus. That's where short-term memories are stored. I will say that a lot of people will come in and they will say, that when they're talking about their loved one, that their memory is great. And I will have to ask them to elaborate on that. And they'll be talking about things from the past. And in Alzheimer's, the disease starts in the hippocampal area, and that is where short-term memories are stored. So the disease will start with short-term memory loss. But it does not affect the cortex where the longer-term memories are stored. So long-term memories are preserved, in the earlier stages of disease. As the disease spreads, it will affect the long-term memories. You have to take a memory from to create a long-term memory from the short-term memory zone, you have to make an association. It has to be deemed an important thing, and then your brain will do that. But just a tidbit of information. So what are the risk factors for Alzheimer's? So age is a non-modifiable risk factor, probably the most important risk factor, but there are others. So family history and genetics is important. There's a higher risk of Alzheimer's with one or more first-degree relatives who have it. There's a history of head trauma often will increase the risk of Alzheimer's. Cardiovascular disease, particularly at midlife, it's really, really important to control things like blood pressure and diabetes and cholesterol, because these will lead to damage and can increase the risk of Alzheimer's and other vascular dementia as you get older. Race is another risk factor. So persons who are African American or Latino are at higher risk of developing Alzheimer's. A low education level, I think of as like associated with social determinants of health, as well as a low cognitive reserve. So if you have a high education level, you're a lifelong learner, you have a high level of cognitive reserve, and you're kind of more immune to the effects of cognitive changes until you're later, until these are later in the course. This is just a graphic talking about the genetics of Alzheimer's. So there are only a few genes that are known to actually cause dementia. The amyloid precursor protein and the presenilin proteins. If you inherit those, 2 copies of those, you will have Alzheimer's, and there are certain families that have that. Most of us will inherit or have some of these. The APO, E, epsilon 4 are the well-known, the best studied of the genetic markers. If you have 2 copies, you're at high risk. 1 copy, medium risk. But again, they're not causative. They just increase your risk. So what are some early signs of Alzheimer's dementia? Number 1, there's some short-term memory loss that disrupts daily life. People may mess up, get the dates of events wrong or appointments wrong. They may increasingly rely on the use of memory aids or family members to keep track of things. They can be repetitive. They'll say the same thing or ask the same question. They may have challenges with planning or solving problems. They might have difficulty managing their finances or following recipes. Things will take a lot longer for them to do. So they have difficulty completing familiar tasks, so they may have difficulty getting to familiar locations or organizing a grocery list. They, again, may lose track of time. They may forget where they are, how they got there. They can have trouble with balance, with reading and driving. They may have some difficulty speaking or writing. So while the short-term memory loss, I want to say, is mostly how most of my patients are presenting with the short-term memory loss, some of them are presenting more of a language problem, or tangent with the short-term memory problem. They're having some difficulty with word finding. So things are just not rolling off their tongues as they should. And they may use substitutions or kind of be a little bit vague in describing something. They may withdraw from conversations, or just they're having trouble following conversations, so comprehension is affected. They may be misplacing things, and we all misplace things. I know I lose things. My husband got me one of those tags, because I think my keys would go missing a lot. Kids would take them and so forth. But when they go in strange places, that should raise a red flag. When they can't really figure it out or retrace their steps, or when they start to accuse people of stealing things, that should raise a red flag. So decreased judgment is another feature in early sign of Alzheimer's. So they're making questionable decisions. They're very susceptible to scams. I saw on a news program recently about how people that are susceptible to scams, that is definitely one of the features that down the road they're at high risk for Alzheimer's. There was I a year or two ago, a lady in Darien who was scammed out of $45,000. And I'm sure all of us have heard of these things. I know in my own, the scammers are out there, right? They try to get in contact with all of them, but they're good. And most of us, I think, have the whereabouts to recognize this pretty quickly. But when they're telling you that they've got your grandson in jail, or it can be really harrowing. So people that again with an early sign of Alzheimer's can be withdrawal from their usual activities and hobbies. They may have a change in mood or personality, so they may be depressed or fearful. Maybe at night, maybe they don't like living alone, they want somebody to stay with them. They may be more suspicious. So what happens when a patient with a cognitive disorder is seen in the primary care setting? I think we're trying to make, it is part of the Medicare wellness exam to screen for cognitive disorders, but a lot of times it is missed. I am getting a lot more referrals, I would say, these days for cognitive changes, for abnormalities on the Medicare wellness exam. But a lot of times cognitive impairment and dementia are not recognized. The barriers will include to identifying cognitive disorders include the limited time. You can only accomplish so much in 15 to 20 minutes. Inadequate diagnostic skill, and that couldn't be further from the truth. So what are the benefits of seeing a specialist for when somebody's experiencing some cognitive decline? So number one, we can help them get an accurate diagnosis. We can help provide some education. We can direct them towards appropriate treatment. We can provide psychosocial support. And we start to engage them in shared decision-making and planning for the future. In terms of diagnosis, the first thing that when I have somebody in my office, I want to know is what is causing the observed decline in cognition. So with my appointments, we always ask for there to be somebody accompanying the patient. We want to have a corroborating history because of the nature of the problem. And I will try to, again, get to the bottom of the cognitive problem. What are the specific symptoms? Is it short-term memory loss? Is it disorientation? Is it a language problem? What was the onset and the progression? Did it occur rather abruptly? Has it been more of a subtle and gradual change in progression? Are there any functional impairments? So I'll go down that list of activities of daily living, find out whether or not they're having difficulties with that, and whether or not they're getting support from that. I'll go, through a personal and family medical history, specifically looking at things like, history of head trauma, alcohol use, smoking, and also talking about any family members who may have had dementia or some cognitive decline. What else? I'll review their level of education, talk about their career. I mean, it's important for me to understand where they were coming from in terms of their level of cognition. My assessment will be different if I have somebody who's, has a JD or an MD or a PhD and they went to Harvard, and, versus somebody who has a 5th grade level of education, maybe from a different country. So all of these things will factor into my assessment. For the physical and neurologic exam, I generally do 2 cognitive tests as part of my exam. the mini mental state exam, which is a basic test, but it's pretty well known by physicians. I'll also do something called a Montreal Cognitive Assessment, which is, it's a little bit more comprehensive, but using the two of them together gives me an idea of where the cognitive issues are, and it's an objective measure for me to help with, again, with my assessment plan. I will do a neurologic exam, and I will do a hearing screen. There is a considerable relationship between hearing loss and cognitive impairment, so I always make sure that that is evaluated as well in my physical. So in terms of lab workup, we do, we make sure that there are basic labs that are recently done. I will always check the B12 level, the thyroid level. I may do some other screens depending on the history. So neuroimaging often is part of the evaluation for cognitive impairment and dementia. My preference is for an MRI when that's possible. CAT scan can be helpful as well. Sometimes I am doing functional imaging, which is looking at the activity and uptake of brain cells of certain chemicals. I'll talk about that in a little bit. Many times I'm referring for further cognitive assessment. This is called a neuropsychological evaluation. They're basically taking my cognitive tests. They're doing it's a much more extensive cognitive evaluation. And they're also looking at psychological aspects, so whether or not depression, anxiety, or other disorders may have an influence on cognition. I mentioned before normal pressure hydrocephalus, which is one of these potentially reversible causes of dementia. Here you can see a normal brain. These are the ventricles within the brain. This is where cerebrospinal fluid passes through and is absorbed. When there is a blockage of this absorption, the ventricles will enlarge and compress this brain tissue. And it leads to a triad of symptoms, very classically, which is like a gait disorder, which we describe as a magnetic gait. So people's feet tend to be like magnetized to the floor. They may have some urinary problems, incontinence in particular, and some memory loss and other cognitive concerns. If we are concerned about this, and this we will pick up on imaging. We may have a concern during the evaluation, and we'll pick it up on imaging. I will refer to a neurosurgeon. What they will do is they will remove in their office some cerebrospinal fluid and see if there's a benefit. If there is, they do something called a VP shunt, which is like a drain from those ventricles into abdominal cavity. That's particularly helpful earlier in when this is caught early, and it's particularly helpful for the gait. It's not as helpful for the memory problem, although there are definitely instances where it can be helpful, and it's something that we do want to rule out. So, as part of my visit, I will talk to people about their diagnosis, and I'll give them, we'll talk about what their diagnosis means, what their prognosis is. So if my impression is mild cognitive impairment, I will explain to them what that is, and also that there is an increased risk in mild cognitive impairment of progression to dementia at about a rate of 12 to 15% per year. When I'm talking about a dementia, most of the dementias that we see are progressive. And so I will describe the typical progression. For example, in Alzheimer's, we can expect a gradual progression over 6 to 10 years. There are people that progress, in a shorter time period, and people that take longer. I mean, there are anecdotes of people, you know, with dementia 20 years out, but typically we're seeing 6 or 8 to 10 years. Over that time, not only will you experience continued cognitive decline, but you will also experience more and more functional problems. So again, earlier in the disease, those instrumental activities of daily living are the ones that are affected, the finances, the medicines, the driving, and the meal preparation. And it's important to have some assistance with those. Later on, we get into the basic activities of daily living being affected. Usually the last activity of daily living to be affected is somebody feeding themselves. In the latter stages of dementia, mobility will be affected. People may become bedbound. You know, there's typically a progression where they no longer are able to ambulate independently. Eventually, they may become bedbound. They may become nonverbal, and we start seeing the end stage complications at that point. We talk about safety concerns as part of our discussion in dementia. The main ones being things like accidents, things like leaving a stove on and causing a fire, or having a motor vehicle accident, or a gun accident. So it's important to assess the risk of these things. And wandering is another concern. I see that with fair regularity. There are programs, there are things that we do if somebody's at risk for wandering. There are medical alert programs. There are GPS things that we can do. Often involves increased supervision, and sometimes things like a locked unit. And we talk about that behaviors can happen at any point really in the disease. I tend to see them most in the moderate stages, mild to moderate stages, and these can range from agitation, resisting care, physical aggression. I had a husband and wife. The husband had dementia, and he was physically abusive to her. It wasn't him, it was the disease, but he broke her leg. People just need to know that these kinds of things are possible, and when it happens, we have to intervene. And in that situation, sometimes we do get adult protective services involved. So in terms of management, I have my approach to management is, first of all, for the medications, we want to, number one, address factors which may contribute to the cognitive decline. Medicines is like my pet peeve, because there's a lot of medicines that can contribute to cognitive decline, and I'm going to talk about that in the next slide. Hearing loss, as I mentioned before, there's a direct correlation between hearing loss and cognitive decline, so I always ensure that people have had an audiology evaluation. We do a screening in our office, and we refer to audiology when that's necessary. We want to treat any anxiety and depression that is accompanying the dementia, because with anxiety and depression, we have impaired attention, concentration, we lose focus, and that affects our input, which affects our output. So we want to make sure that those are adequately treated as well. Sleep apnea is another one big thing. I will often talk to people about sleep as part of my evaluation. If there are symptoms that are concerning for sleep apnea, we're not going to have an evaluation. So things like snoring, or waking up interrupted multiple times a night, or waking up and not feeling exhausted during the day. These are things that might point to a sleep apnea. So I will do a thorough medication history when I see somebody for a cognitive disorder, including over the counter. So medicines that will affect cognitive function in terms of prescribed medicines, are things like sleeping medicines, benzodiazepines, which are used commonly for anxiety, so Xanax, for example. Ambien is another one of my personal not favorites that my mom takes, and it's just very hard to steer people in the right direction, but these are medicines that are not good for our brain function. Also, older medicines that are used for overactive bladder, so like oxybutynin, and other medicines that have what we call ACA or anticholinergic effects. These are dry mouth, constipation, and like a mental cloudiness. I'll look at those medicines, and we'll talk about, either alternatives or trying them off. Some other medicines, so like for Parkinson's and prednisone is another medicine that can contribute to cognitive decline and behavioral changes. In terms of over-the-counter medicines, I have people that will tell me that they take Tylenol PM, and I will tell them no, because it's got Benadryl. Again, Benadryl is an older antihistamine that has anticholinergic properties. So any of those medicines, I really try to counsel them that, try to look at an alternative or counsel it to get off of. Muscle relaxants too. They're also high anticholinergic activity. There's something called the Beers List that the American Geriatric Society has put out that has kind of like a number of medicines that are considered not favorable medicines in general for geriatric populations, but any medicine that's really anticholinergic you're going to find on this list. So moving on to Alzheimer's disease treatments, we have like the symptomatic therapies, the ones that have been around for a long time, which probably many of you have heard of. There are things like Aricept or donepezil. These are called anticholinergic, acetylcholinesterase inhibitors. These will increase the acetylcholine neurotransmitters in the brain. They can have some adverse side effects, particularly gastrointestinal. So if I am many people tolerate them just fine, but if I am going to see a side effect, it tends to be gastrointestinal. So it could be nausea, upset stomach, diarrhea. Rarely can slow heart rate. I've had a few people that were started on this medicine and then passed out, and they had a pacemaker placed. And it doesn't happen that often, but the other medicine that's been around for a while is memantine. It's an NMDA receptor antagonist, and it blocks the effects of the glutamate neurotransmitter. Generally, it's well tolerated. On occasion, somebody will actually be more confused for taking this medicine. The way I think of these medicines, so I think when they first came out, we were trying to show that they made a significant impact on the disease. They slowed the disease. We cannot say that anymore. We don't say that anymore. They have not been shown to significantly slow the disease course. I consider them cognitive enhancers, meaning that a small proportion of people taking these medicines may experience a subjective cognitive benefit, and that can be different from one person to the next. It can be that they're more alert, or they're more participating in conversations. So I liken it to taking Tylenol for arthritis. You're not fixing the arthritis. but you may mask the pain, which is caused by the arthritis. So the newer medicines that are out there, not quite, I guess for about the past year and a half, are the monoclonal antibodies. And these medicines target the amyloid plaque in the brain. As I showed you several slides ago, there was amyloid plaque and tau tangles. The thought process being that the amyloid plaque is what's causing the cell destruction, nerve cell destruction, brain tissue destruction. I don't think that that's 100%. I think there are different models about how this disease is actually happening, but we do know that the amyloid is there in all cases. So these medicines target the amyloid plaque, and they're actually very good at removing the amyloid plaque. The question is, do they have a meaningful clinical benefit? And that, I think, is still unclear. I think the pharmaceutical companies will argue yes, and I'm going to get to that. So the monoclonal antibodies are approved for mild cognitive impairment or mild dementia when there is confirmed amyloid beta pathology. So we need confirmation of an Alzheimer's biomarker. So again, several slides ago, I said as part of the workup, we can do functional imaging and PET scans. So in the past year and a half, the amyloid PET scan was approved by Medicare because these medicines came out. And we could actually do something with that test. The test has actually been around for a long time. It was only approved by Medicare about a year and a half ago. So that will screen. So if I have somebody that presents and I think that they have symptoms of mild cognitive impairment or actually Alzheimer's, and it's mild, and they're thinking that they might want to have these medicines, I'm sending them for an amyloid PET scan. That will demonstrate whether or not there's this amyloid beta plaque in their brain. In order to qualify for these newer medicines, again, you have to have mild disease, you have to have confirmed amyloid pathology, plaque pathology, and you have to have no relative or absolute contraindications. And I'm going to explain that a little bit more in a minute, but these include microbleeds on brain imaging, strokes, history of seizure, the use of blood thinners, so if you take something for atrial fibrillation. If you're unable to do an MRI, that's a relative contraindication because you need to have a lot of MRIs during these treatments. And if you're an ApoE epsilon 4, I mentioned those two genes, if you have copies of those genes, that makes you more at risk for problems with these medicines. You also have to be willing to undergo intensive treatment course and accept the risk for potential modest benefit. So the anti-amyloid monoclonal antibodies, we started off with aducanumab, which came out several years ago. It's since been removed. I don't know if you guys remember when this came out, but there was a lot of controversy about its approval. And actually people that were on the advisory committee when the FDA approved it, they walked off. It has since been removed. Currently available, the one, Sovakembi, which is made by Biogen, that was approved in July of 23. This is based on the Clarity Alzheimer's dementia study. It is an infusion that's given every 2 weeks. In this study, after 18 months, 68% of persons in the group, in the treatment group, experienced a clearing of the amyloid on the brain imaging. and they experienced a 27% reduction in disease progression. So they equated that to about a 6-month slowing of disease relative to the people that did not get the treatment drug. So the antibody that was more recently approved was donanemab or Kisunla, excuse me. That's every 4-week infusion, and that showed about a 35 to 40% reduction, again equating to about a 6-month slowing in disease progression. The main side effects of these medicines are something called ARIA, amyloid-related imaging abnormalities. Usually these occur within the first 6 months of treatment. It happens a little bit more frequently with the donanemab than with lecanemab. Often it's asymptomatic and it's only picked up on imaging, but this is why they have to do frequent imaging when you're getting these medicines. If you are found to have these abnormalities on the imaging, they will, halt the treatment and reevaluate. Again, increased risk if you are you carry that ApoE4 gene, if you've had history of brain imaging, if you're on blood thinners, these other risk factors that I talked about before. There are times where people do experience. There was a New York Times article that came out, I guess, about 3 months ago, where they were talking about these use of these medicines. And in Leqembi, about 20% experience symptomatic ARIA, and of those people, about 25% will wind up in the hospital. These can be seizures. People have died with the medicine. Yes?
You mentioned the 6-month thing. Does that mean it only delays it by 6 months?
Slows it by 6 months.
Okay, so it's, instead of happening immediately, it'll happen 6
Correct.
months later.
For everybody, that's different. You know what I mean? For some people, I would argue that for many people, that's not enough to warrant an infusion every 2 weeks, where you got to sit in a chemo center and get the infusion and you have the MRIs and potentially subject yourself to the risk of this abnormality, the imaging abnormality and the consequences of that, and the expense. The medicines are about, they're very expensive, $30,000 a shot. So it's a very expensive, treatment, and we don't know that much about them. They've only been out for not even 2 years, so I think they're still doing ongoing studies with them. I'm steering away from the treatments now to talk about, to get back to the benefits of seeing a specialist for cognitive impairment. So we provide psychosocial support. So in my office, we have a social worker who works hand in hand with us and the families. We put them in touch with resources, different resources depending on what is needed. Sometimes families will benefit from a geriatric care manager, which is like a private social worker who can help with things like short-term and long-term planning. They can also, for families that are out of state, and if they have a loved one that's living alone, they can accompany them to medical appointments and do other things for them, or arrange for home care. For people with limited financial means, we refer many of them to the Agency on Aging. There are programs that can help support people in their home. There's also things like senior centers and adult day programs that we can put them in touch with. There's a newer program that's out called the GUIDE program. I'm not sure if you guys heard this. I just heard about this like two weeks ago, but it is for people that are not on a Medicare Advantage plan. You can enter into this program and get 27 it covers about $2,700 worth of caregiving for respite. They provide a care manager to come up with a care plan. They provide resources too. And we can get you some more information on that. But this is a relatively new program, and it's great. And you don't have to have limited financial means to qualify for this. At the Alzheimer's Association website is a fantastic resource. Provides resources on caregiver support groups and education groups, treatments. There's also a 1-800 number that you can reach out to at any time to get support from them. So they are a fantastic agency. This is just this is the Agency on Aging website. This is the Guide Dementia program that I was referring to. Again, completely free, regardless of income, $2,600 annual engagements. This is for people that have a diagnosis of dementia. They have Medicare Part A and B, not a Medicare Advantage program. They're not currently receiving hospice, and they're generally at home. The other guide that I typically will refer my families to is the 36-hour day. It's a comprehensive dementia guide, very, very helpful. So what are the other benefits of seeing a geriatric specialist? You plan for future care. So hopefully everybody here has an advance directive, including a living will and a healthcare proxy. That is one of the things that I will ask everybody that comes into my office. Do you have one of these? Do you need one of these? You don't have to go to a lawyer to do it. You can go to Connecticut Department of Health website or Google Connecticut Advance Directive, and you will pull it up. But everybody needs to have a living will and designate a healthcare proxy, or a few of them. I always talk to people about their preferences moving forward. Thinking about your future needs. Let's just say you're declining functionally. How do you want your care to be? Have you thought about this? Have you talked to your family about this? There are lots of different options out there, and I just want people to start thinking about that. We also will talk to people about reducing the risks associated with dementia. So we talk to people about the susceptibility to scams and the possibility of accidents and injuries and how we can support and prevent that. Hospitalizations are more common, and that can be related to, again, the tendency to have more accidents. Maybe it's doubling up on the medicine, or I've seen a lot of medication errors in this disease. Dementia prevention is a big topic. When I tell people, as part of their treatment plan, but also for prevention, it's the same thing for prevention, is we want to shoot for moderate to vigorous aerobic exercise for at least 150 minutes per week. We want to have a brain-supporting diet, such as a Mediterranean or DASH diet. We want to have a rich intake of omega-3 fatty acids. We want to restrict sweets and processed foods. So here's where Kennedy has some we're paying attention to him, because I think that's some of his thoughts on this are good. Smoking is a no-no. Alcohol, limiting it, generally 2 glasses a week or less. We want to have regular social engagement. That is so important, staying connected to others. We tend, I think, as we get older, to close and close and close our social circles, and we should be really striving to keep them open. We want to be doing things that are cognitively challenging us. So, the Norwalk Community College has like the Lifelong Learners program. The sure the library has a lot of programs. You want to do things that are challenging your brain, whether that's learning how to play bridge or doing the crossword puzzle every day at the New York Times, or watching Jeopardy, or things like that. And sleep is really, really important. I think we're only we know that it's important. We're only starting to learn, why. The brain has a renewal process during sleep, and if we don't get enough sleep, we're not renewing our brain function. So we need to really have good sleep. The medicines do not help with that, by the way. Ambien does not help with that.
Can you get too much sleep, or sleeping in the middle of the day versus at night? Is that any kind of an issue?
Well, I don't know that we know that I think it's best to sleep at night, but I think if you're sleeping too much, there could be a problem there. So you probably want to talk about it with your primary care physician. I have a lot of people that, take cat naps during the day. You don't want to be getting a lot of your sleep during the day, because that can be very disruptive to your sleep at night. Helmet and seat belts, to prevent brain injuries is also important. This is we had a dementia talk at Sanford Health about 4 months ago, and this was just one of the slides that I thought was so interesting, where the presenter was talking about all of these modifiable risk factors for dementia. About 45% of dementia is potentially modifiable, or the dementia risk factors, excuse me. Things like, hearing loss, cholesterol, mood, brain injuries, physical inactivity, diabetes, smoking. So there's so many potentially modifiable risk factors. Age we know is not one of them, but it would be great if somebody could figure that one out. But there's a lot. I found this, the Brain Care Score, it's on the Massachusetts General Hospital. If you Google Massachusetts Brain Care Score, you can pull this up. And I took this quiz and I got a 13 out of, I think it was 21. But it points out where you can improve to improve your brain care and your brain health. So you guys might want to check it out. That's it. I think I've been talking exactly for an hour. So.
That was a great presentation. Thank you. 2 questions. Have you given this presentation or similar ones at Founders Hall?
At Founders Hall?
Here in Ridgefield, yes.
I have not been there.
Okay.
You mean would I, or?
Yeah, would you?
Oh yeah, I would do that. Yeah.
Okay. And the second question is: in the town of Ridgefield, does the town have a system for identifying older people living alone who should not be living alone?
Well, I don't live in Ridgefield, but I know that I'm in Weston, and our social services department is, a very active department, and they might get calls from, it depends, from concerned neighbors, from police, or from EMS. If they're going to somebody's house for repeated falls, they might get involved. But yes, that's what I think the social services department is there for.
When you're talking about things like Ambien and stuff like that, right now, my father was doing it, I basically kind of weaning off of it and I've been getting enough vitamins or melatonin at night instead. Is melatonin and stuff like that bad for?
We use melatonin. I would much prefer to use melatonin than Ambien. We use it in the hospital, we use it, I would prefer that. I talk about sleep hygiene to most of my patients. We talk about how important it is to keep a very consistent schedule. You gotta get your body on the schedule of waking up and going to sleep. And your body will kind of naturally get there. It will want to go to sleep if you do this. We talk about getting, staying active, getting exercise and being active during the day, limiting those daytime naps, make them cat naps, 10, 20 minutes. Alcohol, it sedates you initially, but then if you're doing it at night, it's gonna throw your sleep off. Same thing with smoking. What else? Caffeine also. I try to tell people 1 cup in the morning, you take it afternoon, and that caffeine is gonna be in your system for a long time. It takes a while to get out of your system. So I really stress the importance of sleep hygiene. If somebody could fix sleep with a good and safe medicine, they would be like gajillionaires. I mean, they really would.
When you talk about hearing loss as a cause or are you talking about unattended, or does that lower with hearing aids?
It's abated when you fix it. We just want people to have the treatment, which is having a formal audiology assessment, and if they qualify for hearing aids, doing that, ideally. Go ahead.
Thank you for your objectivity on the newer drugs. Are there any of the newer drugs on the market that can be taken if you're on a blood thinner?
Well, so there are relative contraindication. It's not an absolute, to my knowledge, that but it's not. I would definitely be concerned because of this ARIA, the propensity towards these microhemorrhages. If you're on a blood thinner, that will increase your risk. So no, it's not an absolute contraindication, but it's something that I would definitely incorporate into my decision into referring to somebody. And by the way, we don't treat, so you have to go to a specialized center to have one of these medicines. So Yale is doing it. You can get a referral to one of the neurologists or to Adler Center, and Columbia. That's where we are. Most of if I have somebody that's interested in the treatment or at least learning more about the treatment, they are going to Yale for the most part.
How about the 81 milligram aspirin regimen?
That really, I wouldn't say that that's a contraindication. I'm more talking about the medicines for atrial fibrillation.
Thank you. Do you have any markers to look for to indicate that maybe it's time to move from somebody being at home to being in care, particularly for an individual who the primary caregiver would be, a spouse who's elderly as well, and you watch the progression of the disease in the ill spouse progress pretty quickly. Like, are there certain things to look for to be able to say, it's time, to move on?
So I really want to incorporate what, I try to put myself in their shoes, right? A lot of people want to stay home. There are people that are open to, assisted living or memory care if it got down to that, but I would have a conversation. It is definitely more challenging, I think, being at home, particularly if there's behaviors or if there's wandering. There are certain things that would say, okay, we really need to have a conversation about memory care. This is unsafe. But I try to work with that family's, the person's or the caregiver's wishes. And we try to have a mutual kind of discussion about that. So I don't know that there's one thing, but wandering, behaviors, like I was talking about that the wife who was physically assaulted by her husband. That we needed a change there. There's certain instances where we need something like memory care. But I think for the most part, we're trying to talk. We're trying to have them meet them halfway.
Sorry, can I follow up?
Yeah.
Do you involve the patient in those conversations as well?
It depends.
Okay.
it depends on where they are in their disease. If they're too far along, and I don't think that they can really participate, I won't involve them. Yeah.
Thank you.
Oh, go ahead.
The various traits or characteristics that you described, are they all inevitable, or do people get some? In other words, does everybody have wandering eventually?
No,
or-
not at
No,
all.
I just wanted to clarify.
No, you know, we see behaviors and mood changes and things like that, but there are some people that we never see that. There are some people that are just a complete handful. It is the spectrum. It's the spectrum. And a lot of times I will see people with certain personality traits that are much more magnified when they move into a dementia. So that happens too. You were next.
What about so-called brain vitamins like Mariva, Prevagen?
I don't generally recommend them. I think the pharmaceuticals are in that for mine. And there's not enough regulation. And, you know, I think taking a multivitamin is, you know, a good idea. Most of us are not getting it from the diet. I'm a firm believer in diet. Like, I just think we have to do better for ourselves and exercise. There are also just case studies, if you look at it, of people that have really slowed down their really done well in terms of slowing down the cognitive decline, even reducing the amyloid plaque when they are committed to these lifestyle changes.
There was a presentation from CNN called The Last Alzheimer's Patient, and it's about diet and exercise.
Yeah.
Literally.
Was that Sanjay Gupta?
Yeah,
Yeah.
it just literally slowed down the progression significantly. You know, she was early in her diagnosis, but it was pretty interesting. But
Yeah.
yeah,
I'm a medical doctor. I think I love prescribing medicines, but not for this. I don't, I think if we can make all these other changes that we talked about, I think we're doing so much better for ourselves. I mean, their medicines do become necessary, and particularly for when we do encounter behaviors, certain things, but in terms of your treatment, go ahead.
You mentioned vitamin B12.
It is, well, I mean, it's part of one of the lab tests that I do. So like we'll do, standard set of labs. B12 deficiency, if it's significant, can cause some cognitive changes. So I will prescribe B12 if it's low. Go ahead.
You mentioned the importance of assessment as part of your talk here, and that maybe a primary doctor may not know this, or a primary doctor may refer a patient to someone like yourself. The challenge, and I'd like to get your help on this, is that, so I have, my elderly parents, right, and my mother, who I think should be assessed, but if she finds out that I think she needs to be assessed, she's going to freak out, and it's going to stress her, and she's going to get anxiety, and I'm really worried it'll make her worse. Now, there's very, very light symptoms right now, and I don't know if it's going to do more harm than good, or do I wait? It's a struggle.
Yeah, ooh, that's a hard one. Sometimes people will say, make little white lies, like, this is like this is a free exam that, Medicare recommends this for all of our patients, and your doctor so-and-so wants you to have this test. And so sometimes we do white lies. I don't know. I mean, you heard a lot about what I do, but, it's not, obviously not the same as an assessment, but, and I'm assuming that, do you live with them?
No,
But they have support.
They're
Yeah.
good enough to be able to.
So sometimes you can make a little fib like that and get them in and talk to the doctor just about, in advance about maybe what you're seeing, so you don't have to talk about it so much at the visit. There are ways that we can get around it. Yeah. Go ahead.
So you talked about the correlation between kind of a delirium and a dementia. And if the onset was more a delirium that sort of prompted into a dementia, do you typically see progression from there, or can it sort of, like, once the illness has been resolved, COVID, can you stay stable, or do you see progression usually from that point on?
I mean, it sounds maybe like, so a delirium can like unmask a dementia. Maybe somebody who's doing okay and then boom, they're sick and they have this delirium and now they're, they haven't gotten back up to their baseline. I think that's what it sounds more like to me, is that maybe it's unmasked the dementia and that you would expect some decline. Again, I think that might be something, if you're seeing anything, that you want to talk to a specialist about, or your primary doctor about, yeah.
I'm curious what your thoughts are on the use of cannabis products as a sleep aid.
Oh,
Serious
Can
question.
you repeat that?
cannabis, he wants to know about using cannabis products as a sleep aid.
Correct, yes.
I don't have an objection, but it's not something I prescribe. So I have a few people that will take, CBD products or cannabis, gummies for sleep and or anxiety, and I think if it's helped them, I don't have an objection to it.
I know there haven't been a lot of studies done on it.
There have not, and there potentially could be an interaction with the medicines if there's medicines that I'm prescribing. So I don't, but I don't stop them from doing that. I just want everybody to be on the same page. I want people to tell me about any over-the-counter or any other products that they're taking.
Thank you.
I'm just curious, have you noticed any, or do you know of any real differences between the American federal, for pharmaceuticals, what's passed and whatnot, compares to some of the advanced European countries? Have there been big differences, or is it pretty much the same?
They're similar drugs, but I don't know much about the European drugs.
We may have to learn.
Yeah. I really don't, I'm just trying to get myself familiarized, to be honest with you, with all the changes that have happened with these medicines. So it's just a lot to take in, but good thought.
Do you have any experience or feedback for, I heard lion's mane as a supplement, is that helpful?
No, I couldn't tell you about lion's mane. I have people that take different supplements, but no supplement has the evidence base to back it in terms of cognitive decline. Yeah.
So I want to thank Dr. McElhone for this is a three-part series, and this might only be the piece that you need, but the next one is on March 6th at 1 p.m. here at the library, and it's called Navigating Communication Challenges. Danielle Taibi, never say your last name properly. She's a dementia specialist, and she can tell you a little bit about what that program is in case it's of interest to you.
Yeah, I mean, if you like this, which I love, Dr. McElhone's approach, I love what she has to say about pharmaceuticals and being realistic about how much of an impact, she sees those have on people. But I'm an occupational therapist that works with dementia every day. So I'm in multiple assisted livings right now. I've chosen that. That's what I want to do. So I'm in a memory care unit almost all day, at least 3 times a week. So I'm seeing all different levels of what we talked about today, from the more moderate stages usually to end stage at the facility. So I know there was a question about that. So our presentation on communication goes through kind of the different stages of dementia, the different activities that are appropriate at those different levels. Questions like, when do you consider that maybe somebody has to go to a facility? Or can you work out ways to keep somebody home? What are those things? A lot of dementia care comes down to communication. At each stage of dementia, you have to change your approach because the person's changing, and you've got to be on their level. You kind of have to be in their world at all times. So the hardest challenge for people working with people with dementia is learning how not to reorient argue or try to use logic. It does not work with dementia, and all of us want to do it, right? Especially people from the Northeast. We really like to use our smarts to try to figure things out. In this case, you really can't. So we go through communication early stages, from how to make somebody decrease their agitation if they're starting to realize something's wrong with them. We tell you how to handle those situations to bring them down, because it's very frustrating for somebody when they're forgetting things or realizing that they're losing their mind, essentially. 2 more of the moderate stages where you have to slow down your pacing, use more gestures, make sure you're facing the person, use certain body language, to the end stages of dementia where we're talking just touch, sensory activities to calm that person and to offer comfort, right, and familiarity. So we go through all of that during that series. And we also talk a lot about, towards the end, we talk about hospice, because today we talked about how some of the drugs don't work, and we all want to hear that there's some magic drug. But I do talk to people about, towards end stage, there is a great program that not enough people utilize, and it's called hospice. It's a program that supports the person where they are, does not speed up life, does not slow down life, meets the person where they are, but it becomes about comfort care. And that is one thing that I can honestly say, we see people living sometimes longer on a hospice program where they're not in pain anymore, they're not agitated, they're treated in a way that makes them comfortable, and that in itself makes them live longer. They've done studies on it and found that actually works, and they live a more fulfilling life at the end of life. So we go through all that.
Are they that day? Do you offer that at any other point, or?
We will be,
We will record this presentation here, and we can, if you sign up for it.
And I've done that one in a couple of libraries now. I'm doing it in a couple assisted livings. The one that I'm doing this week is closed, but there are going to be others that are public. So yes.
This one is being recorded today, and the subsequent ones will be recorded as well.
And on the IBMA site?
I'm sorry.
Did you go on your, IBMA?
Yeah, or at the Ridgefield site, but yes, we'll get it on.
And you're welcome to sign up if you haven't for our email list, so that you can have access to knowing when these are around town or in other towns, or public, or Zoom. I've done Zooms as well.
A question for the doctor. Can Alzheimer's be a cause of death?
Yes. I mean, it's, I want to say the 5th leading cause or 6th leading cause of death, yeah. I mean, in the later stages, we didn't really talk about this, but you progress in mild, moderate, end stage or advanced stage, and we start to see complications, which would include infections, aspiration, pneumonia, trouble swallowing, weight loss. When I see these people lose their mobility, they're completely dependent functionally. When I have a patient who is there, we start talking about goals of care and hospice. So we start talking about these things.
And then the final one is just long-term advanced care planning, which is the financial piece, just trying to figure all that out. So that one is on March 20th at 1 o'clock. Josh Weinschenk. So thank you for coming.
Thank you.